Moving forward to our next speaker, Lisa Baum, MA. Lisa is the lead occupational health and safety representative for the New York State Nurses Association, fondly referred to as NISNA. Until recently, she also served as a member of the CDC's Healthcare Infection Control Practices Advisory Committee. Lisa has over 25 years' experience in the field of occupational safety and health. Lisa, the floor is yours.
Thank you for having me here today. NISNA represents about 44,000 nurses in the state of New York and one facility in New Jersey. We represent healthcare workers in acute care facilities, long-term care facilities, ambulatory care clinics, correctional facilities, county departments of health, schools, you name it. And it gives us a unique opportunity to see what's actually going on in the front lines with infection control, which obviously has become a more significant issue for all of us in the past few years. Nosocomial infections, or healthcare-associated infections, have improved somewhat over the past few years, but they're still extraordinarily high. They cause massive rates of infection and suffering and extraordinarily high numbers of deaths, both in the United States and elsewhere in the world. Now, a hospital-associated infection is really considered a never event, something that's never supposed to happen. And in fact, they can be prevented, but far too many of them are not. The data related to HAIs, unfortunately, rarely includes airborne infectious diseases. And there are a number of reasons for that. I don't think we have time to go into all of them, but keep in mind that when you see these high numbers, the numbers are actually so much higher when we consider how many airborne transmissible diseases occur in healthcare settings and are continuing to occur. Unfortunately, when we see rates of transmission that are high in the community, healthcare facilities tend to state that any infection people got in the community and not in their facility, and therefore don't need to be counted in their numbers. So the lesson we've really learned from all of this is we don't gather the data. So airborne transmission doesn't really exist in healthcare facilities. Most of the data we've had to look at with transmission has been from other countries where they do, in fact, look at the type of job people do, where they work, and where they may have been infected. But in this country, we've gathered almost none of that data, with two exceptions. One is for a period of 6 months in 2021, OSHA put in place an emergency temporary standard for COVID in healthcare facilities. We can debate how effective that was, but one of the requirements was that healthcare facilities maintain a log of staff who were infected with COVID. They did not have to differentiate between whether it was community-acquired or an HAI, because they knew they'd get into too many fights with the healthcare industry over that. We at NISNA did an analysis of some of that data. We estimate that we received those logs for about 10% of the hospitals in New York State. And for a very short amount of time during the Omicron outbreak, we counted 14,000 infections, again, in 10% of the hospitals in New York State. This is only the healthcare staff, not the patients. And these rates were higher than were being seen in the community. So we know that a year and a half into the COVID pandemic, we were still seeing massive amounts of infection within healthcare facilities. Another source was from the US Centers for Medicare and Medicaid Services, which for a significant period of time during the COVID pandemic required long-term care facilities to report every week the number of residents who were infected with COVID and the number of staff who were infected with COVID. And so that gave us a lot of data. We could extrapolate that to other types of healthcare facilities, but the actual data only existed for long-term care. And again, we saw extraordinarily high rates of infection, and we saw rates that were higher than in the community. So we know that these diseases continue to be spread at very high rates, even well after the initial period when COVID began. So why are HAIs of all kinds still high? Well, understaffing, and I'm not just talking about understaffing of healthcare providers, because healthcare providers do some of the cleaning that occurs in a room, but the environmental services staff who do the majority of the cleaning, those rates of staffing really affect how well disinfection happens in healthcare facilities. We have fast room turnover. An empty room makes no money. So in the desire to put a new patient in a room once it becomes vacant, we don't necessarily take the time necessary to completely remove all pathogens from that room. There is a lack of understanding, and then I would argue that means a lack of training, on the proper use of disinfectants. There's a belief that the stronger, the better, but it doesn't mean that they're being used properly. For example, most people in healthcare don't understand the concept of dwell time, that just having a disinfectant touch a surface doesn't immediately kill all pathogens, but a surface needs to remain saturated with that product for a certain amount of time. That depends on the product, and it depends on the pathogen until it's killed off. So there often is not adequate dwell time. A lack of testing to determine if the infection control procedures at a facility are adequate. Testing may occur after an HAI has occurred, but not before to prevent it. And we continue to have highly inadequate controls for airborne transmissible HAIs, and we'll talk about that some more. So what are some of these controls? There are not nearly enough isolation rooms and AIIRs, which are airborne infection isolation rooms, or commonly called negative pressure rooms. An isolation room does not have specialized ventilation, but it does physically remove an infected patient from close proximity to other patients and staff. The AIIRs not only prevent the virus or other pathogen from seeping out of the room, but also filter exhalation through HEPA filters before it leaves the room. Very few of these still. Hospitals created a few more after the initial SARS epidemic, but we still don't have enough. And by the way, AIIRs can be created not without too much difficulty temporarily. And there are excellent sources for how to do that. And you can even create AIIR spaces that cover an area that has a number of patients in it. But we see very little of this. Overcrowding. Emergency departments are tremendously overcrowded. If you've been in an emergency department in most places, you can see this. Patients are stacked up one right next to another. And while we know that the distance issue with airborne pathogens is complicated, certainly putting people with airborne infectious diseases right on top of each other is going to spread disease faster. And even in inpatient units, we see what we call hallway patients, patients who actually, their room is actually a hallway, even when they have infectious diseases. And again, this is an overcrowding issue. We see delays in triage due to understaffing. There are multiple levels of triage in an emergency department. Yes, there's triage where you're taken into a room with a nurse or a doctor. They ask questions, they examine you, they take certain vital signs. But prior to that, there are a couple more layers of triage that have to occur. just looking around the room to see people's condition. Is someone gasping for breath? Has someone fallen on the floor? Asking basic questions upon entry about travel, symptoms, etc., is extremely important. And the faster that person gets asked those questions, the faster they can be masked and isolated and further triage take place. If that doesn't occur, then that person is potentially infecting huge numbers of people in the waiting area. And again, that takes adequate staffing. We don't see separate space for people who have airborne infectious diseases in emergency departments. Mostly people are separated with a curtain, and a curtain is not a wall. And in fact, those curtains are rarely washed. So even infection through contact is problematic. Inadequate ventilation. You should have just enormous levels of ventilation and fresh, clean air moving through certainly crowded areas like EDs, but frankly, all areas of the hospital. And this is a real point of contention where, although hospitals have requirements for higher levels of ventilation than other types of buildings, it is still in most cases inadequate. And by the way, ventilation isn't just important to prevent the spread of airborne infectious disease, it's important to decrease exposure to chemicals. And right now, we've been looking at the effects of wildfire smoke on healthcare facilities, and ventilation is important for that. Ultimately, there is a lack of understanding of how air moves in a space and how airborne pathogens spread. One of the problems here is there is a science related to this, and it is not a healthcare related science, right? There are people in the field of industrial hygiene, there are ventilation engineers, etc., and they truly understand how air moves, but they are often not included in groups that make these types of decisions. So there are assumptions, for example, that if I am outside the room of a patient with an airborne infectious disease, I don't need to wear a respirator because the pathogen won't make it that far. But we know that, in fact, is not true. So who is out there protecting patients and staff from infection? Is there anyone in charge? That's been a problem. And certainly when the COVID pandemic began, healthcare workers felt that no one was in charge and no one had their backs. And in fact, I agree with them. The CDC is responsible for public health, but it is not an enforcement agency. It creates guidance, and it is not an occupational health and safety organization per se. HICPAC, which I was briefly a member of, is an advisory committee, or was an advisory committee to the CDC that advised the CDC on the best infection control practices for the healthcare setting. Changes were made over the past couple of years in who was represented on these committees, and HICPAC was being opened up more to those representing frontline workers and even people who had a greater understanding of industrial hygiene. Unfortunately, the current administration did away with HICPAC, and we were all summarily fired. So there is no organization now advising the CDC. And in fact, we see a lot of chaos going on at the CDC now, and those with the most years of experience are being tossed aside, and people without medical understanding are being put in their place. Now, while I said the CDC is not a regulatory agency, typically what would happen in the past is that state departments of health would take CDC guidance and then turn it into regulations for their state. How will that go going forward? I don't really know, because the guidance coming out of the CDC has been changing dramatically, not necessarily in ways that I would consider good. We also have OSHA, which unfortunately, though it has the regulatory authority, has delegated and ceded a lot of authority around healthcare and infectious disease to the CDC, which has been unfortunate because they have the mandate to protect workers, but have kind of stayed with their roots of blue collar work and have not really expanded as strongly as they need to in understanding and putting forth protections for healthcare workers. In the field of occupational health and safety, we follow what is called the hierarchy of controls, which basically says that there is more than one control, typically, to protect people from a hazard, and they are not all equal. Some are better than others. This hierarchy is in effect, whether it's an infectious disease, a chemical exposure, radiation, violence, slips and falls, anything. Now, as you'll see, PPE is at the bottom. And the reason PPE is at the bottom is it is not a great control. It is extremely uncomfortable to wear, particularly for people who work very long hours. A typical nurse shift is 12 hours, and during a crisis, maybe 16 or more hours. It often does not fit well. It's very hot. It can be difficult to breathe through. And when and if it fails, and it does fail, the worker is completely exposed to the hazard. We cannot use all of the hierarchy for infectious diseases. Elimination has only been possible with high vaccine adherence. For example, smallpox, we've been able to eliminate, but for the current diseases we're dealing with, we've not been able to, nor can we substitute. But what we should be focusing more on are engineering controls, the most important of which is ventilation. Now, we need, as Kevin talked about in our introduction, a layered approach to controls. We need engineering controls like ventilation, negative pressure rooms. We need administrative controls like testing, isolation, immediate identification and isolation, staffing, etc. And we do need PPE, but we cannot depend solely on PPE. So what's the current state? Well, not great. We are not seeing significant changes in ventilation. We do see more portable HEPA units now, and that's good, but it is not enough. The ASHRAE, the American Society of Heating, Refrigeration, and Air Conditioning Engineers, did update their guidance on ventilation for healthcare facilities in 2021, ASHRAE 2021-170, but it is not required to be followed by law. There are two types of ventilation. One is general dilution ventilation that comes through the building's HVAC system, and it decreases the amount of airborne pathogens by diluting it. There's also what we call local exhaust ventilation, where you bring an exhaust vent right to the source of the hazard. And those exist, but I have never seen them in a healthcare setting ever, and nor has anyone else that I know in this field. They include ventilated headboards, which have been created by NIOSH. There's also information from the US military on how to create these, and hoods that are sort of like a wooden box over the head and shoulders of the patient that pull that pathogen straight out of the air from their mouths and nose and put them through a HEPA filter. These would be extraordinarily helpful in stopping the spread of disease, but again, they are not required by law, and I never see them. We're still focusing on respirators for use during aerosol generating procedures, even though there's plenty of data that shows that there's large amounts of pathogens present in the air, even when AGPs are not being conducted. We still have difficulties getting the right size and model of N95s available for use on the unit. N95s are problematic on their own. Supply chain problems, right? Because they're disposable. They don't fit a lot of people because people have different sizes of faces. You need many makes and models and sizes. They have to pass a fit test, and then you have to have the size and make and model that the person passed a fit test for available for them. We had a COVID outbreak very recently where it took hours to get all the appropriate N95s onto a unit. We don't see significant changes in supply chains to safeguard access to PPE. There are a variety of reasons why there can be problems with supply chains. And until there's a switch to reusable PPE, we're going to continue to have these problems. And we had organizations like NIOSH who were looking into creating better PPE for the healthcare setting. They're really the only organization that has done work like that, and they've been virtually destroyed. Although in name they still exist, the vast majority of their staff have been fired, and so we don't have a functional NIOSH. We learned a lot of wrong lessons during the COVID outbreak. For example, if too many healthcare workers get infected and you have a shortage of staff, the answer isn't to staff up better or protect them better. The answer is to just say that they can come back to work sooner while they're still infectious. And in fact, that's what happened. If too many patients need AIRs and we don't have enough AIRs, we'll just say you don't need them anymore. If there's a shortage of PPE, instead of finding better ways to handle PPE, like switching to reusable PPE, they just made staff wear disposable PPE over and over again for periods of up to 2 weeks or more, or used unproven methods to decontaminate it. Both of these affect the fit, not necessarily the filtering capacity, but the fit of the PPE, and poorly fitting N95s do not provide a lot of protection for workers. And ultimately, the CDC just declared kind of crisis conditions where really anything goes, and very few protections were needed. However, there's good news. And the good news is there's very practical and proven ways to prevent the spread of infections in healthcare facilities. Have better and faster identification and isolation of infectious persons. Conduct more testing so that we know when people who are asymptomatic or have very mild symptoms come into a healthcare facility, we can determine that they have an infectious disease and take steps. Improve ventilation, both general and local. Secure the supply chain better. Switch over when possible to reusable PPE, particularly when we're dealing with respirators. We should be switching over to elastomeric respirators, PAPRs, and newer PPE called CAPRs, which is even better than PAPRs. Improve staffing levels. We need better documentation to learn who's getting infected, where they likely got their infection, so we can follow trends and take steps based on that. And finally, we need to let NIOSH do its job, because it does an outstanding job, or has in the past. Ultimately, we need regulation that requires these, because when we leave it to healthcare facilities to take these steps on their own, as we've seen, they don't do it. So we need a change in the regulatory climate. Thank you.
Thank you, Lisa. Very informative, and it's sad about NIOSH. They say there's only maybe 6 or 8 people left there. But thank you so much, and thank you for representing NISNA.